Hello, my name is Kevin Choo. I'm an orthopedic surgeon here at ONS, specializing in hip and knee replacement surgery, and I also treat patients with hip fractures and other hip injuries as well. I want to thank the ONS Foundation as well as Greenwich Hospital for the opportunity to give this talk today. I'll be speaking about optimizing outcomes in hip fracture patients. As some background, hip fractures are a big problem in our patient population, and we increasingly see it in a geriatric patient population as well. Over 300,000 people are hospitalized with hip fractures annually, and it ranks among the top causes of disability worldwide in the elderly. In the year 2040, it's estimated to have an annual healthcare cost reaching nearly $10 billion in the USA alone, and on an individual level, it represents a significant risk of morbidity and mortality for these patients. About 5 to 10% of patients will die 30 days within a hip fracture injury, unfortunately, and in some studies up to 50% at 1 year. So it does represent a significant mortality risk for our patients. And the vast majority do not, unfortunately, return to pre-injury level of function. A big reason for this is the issue of frailty, and this is something that we're beginning to understand more and more over time in the medical literature. Frailty is an age-related syndrome with marked vulnerability to adverse health outcomes. Patients with frailty have physiological decline with weakness, fatigue, increased medical complexity, and a hallmark being a reduced tolerance to medical as well as surgical interventions. There are various frailty indices utilized. They are all highly associated with mortality risk, and they tend to be a combination of various criteria, including medical comorbidities, functional status, as well as performance testing. As a background for hip fractures, one point to clarify is that hip fractures are actually proximal femur fractures. So these are fractures in the femur bone. And so when you ask patients or even other medical professionals where the hip is, it can often refer broadly to a large area around the hip region. But when we speak about hip fractures in particular, we really talk about injuries to the proximal femur. In terms of the anatomy of the hip, we think of it as a hip ball and socket joint. So if you look at the image to the left of the screen, you can see that there is a femoral head, which is the ball and socket joint. On the acetabular side, on the pelvic side, we often refer to that as the socket. And as I mentioned, the rest of the proximal femur bone is commonly affected in hip fractures. That can include this area just below the femoral head, which is known as the femoral neck. This area just lateral to that, which is between these two areas called your greater trochanter and your lesser trochanter, and the area beneath it, which we refer to as the subtrochanteric region. And these also delineate the three main fracture types that we deal with. Again, first being the injury to the femoral neck, which is the area just below the ball joint or the femoral head, a fracture to the intertrochanteric region, and then the injury to the subtrochanteric region, which is essentially an injury to the shaft of the femur. Surgical treatment is guided based on the anatomic location primarily. So if we begin with femoral neck fractures, there are two variations of this, both again being in the area just below the femoral head. These can either be non-displaced fractures, as you can see to the left here, or a displaced fracture, which you can see to the right. And this helps to dictate management as well. Non-displaced or impacted fractures are generally managed with fixation with a metallic implant. Historically, this has traditionally been with cannulated screws. This is sometimes referred to as hip pinning, and this allows for controlled collapse as well as compression of the fracture site. Unfortunately, there is a high rate of revision surgeries for this injury, up to 20% at 1 year. More recently are newer devices that help to solve this problem of the high rate of revision. And these are essentially plate and screw combinations which utilize a screw and a bolt which slides within a side plate. And this is found to be biomechanically stronger than screws or pinning and is therefore increasingly used. For displaced femoral fractures, these have a poorer healing capacity in part due to a disrupted blood supply to the femoral head. And so our preference is generally to replace these rather than try to repair or fix these with metal implants. So the first is called hemiarthroplasty, and in this surgery we replace the femoral head and we leave the acetabular or socket side alone as it is uninjured. These patients generally have a lower dislocation rate when compared to a total hip replacement, and we know that these patients typically are best served with a cemented stem versus a non-cemented stem. As I mentioned, the other alternative surgery for this is a total hip replacement. This is essentially a very similar surgery to a hip replacement that one may receive for arthritis or a degenerative condition. So in the surgery, we replace the femoral head as well as the acetabulum or the socket. This has possibly better functional outcomes compared to a hemiarthroplasty, but does have a higher dislocation rate. Next, again, is the fracture to the intertrochanteric region. And these are generally treated with fixation of the injury, either with a plate and screw, like I mentioned previously. This is more of a historical procedure for this injury and is useful for fairly simple pattern fractures only. More commonly now, we use a device called a cephalomedullary nail or an intramedullary hip screw, and this can be used in simple and complex pattern fractures. It is stronger biomechanically and is therefore used much more over time. For injuries down to the shaft or the subtrochanteric region, these are relatively less common injuries. They are challenging fractures due to muscular attachments, and these are traditionally treated with fixation with a cephalomedullary nail. In terms of various strategies for success, in addition to achieving a good surgical outcome, we really know that managing patients with these injuries is a team-based approach and involves multiple areas from not only the surgeons, but also hospitalists, geriatricians, anesthesiology, and the emergency department. A big issue we're learning more about is the issue of timing to surgery. And this has really been a change in paradigm over the last 5 or 10 years. And again, it deals with the idea of frailty and the health status of our patients, generally speaking, when they come in with these injuries. If you look at the diagram to the bottom of the screen, this gives you an idea of the general health status of a patient, or conversely, frailty on the y-axis and then time on the x-axis. Under the old model, we felt that patients were generally in good health, and the fall and the fracture would be the insult. And we would expect that the patient should recover and stabilize before surgery. So if you look at this diagram, you have a patient who is generally in good health. They would have a fall, injury, arrive at the hospital essentially at their worst condition, and we would anticipate that they should slowly improve. And so the old paradigm was to admit these patients, essentially wait and see how they did, and then give clearance for surgery. As I mentioned, there's really been a change in our paradigm in how we see these injuries. What we know now is that patients that have these fractures are not, generally speaking, healthy patients that have an unfortunate fall or bad luck and have an injury. These are patients whose frailty is becoming a bigger issue for their quality of life. The fall is not the insult, but more an indicator of their overall health status. And therefore, we believe that patients generally do not improve with waiting in the hospital. So if you look again at the bottom of the diagram screen here, you have a patient who is in relatively poor health. The fall, again, is the indicator or a marker of increasing frailty or decreasing health status. When they arrive at the hospital, they're not at their worst condition, they're actually near their best condition. And so this is something that when I spoke to a geriatrician about this, they said the patient's best health status is actually the moment he or she comes into the hospital. And sitting in the hospital with the broken hip, not being able to sit up, not being able to walk, generally health status can deteriorate over time. And so our new paradigm is to admit patients, evaluate and manage any modifiable risk factors without really waiting for a clearance, again, more trying to optimize anything that we can change, and then proceeding as soon as we can do so safely. The American Academy of Orthopedic Surgeons has released evidence-based guidelines on this topic, and they recommend surgery within 48 hours of admission to the hospital. And multiple studies show that this is associated with a shorter postoperative hospitalization and decreased mortality rates for these patients. The Association of Anesthetists has gone further to recommend that they should facilitate, in combination with the surgeons and the emergency staff, facilitating having these surgeries completed within 36 hours of the injury. And this is even being pushed even further. So this is the result of a multi-center randomized trial based in Canada with nearly 3,000 patients, randomized to conventional care, which was surgery within a day or two, typically within 48 hours, versus a cohort of patients who were taken essentially from the emergency room directly to the operating room within 6 hours of presentation to the hospital, which is very quickly. And they found that these patients actually had no worse outcomes in terms of mortality or morbidity after the surgery. They had a lower risk of delirium, lower risk of urinary infections, and they were actually faster to stand, mobilize, and go home after the operation. Notably, patients who came in with an elevated troponin level actually had a lower risk of death compared to standard care. And I thought this was a very interesting finding, as that would be the characteristic high-risk patient that typically would come in with a high troponin, would then be delayed for surgery conventionally, have a cardiology evaluation, cardiac echocardiogram. And in fact, a study like this tells us, again, with the new paradigm that patients tend to deteriorate the longer they wait. In fact, it may be beneficial to act even sooner. There's currently a larger study undertaken now that is seeking to verify this at a larger level. In regards to the management of anticoagulants, this is a very common issue for our patients. In general, for patients on Coumadin or warfarin, we desire to initiate vitamin K immediately on admission and potentially administer PCC as needed. For our patients on antiplatelet medications such as aspirin or Plavix, this is not considered to be a reason to delay surgery, and so we should plan to proceed normally. On our patients who are on novel oral anticoagulants or direct anticoagulants such as Eliquis or Xarelto, we still recommend waiting about 48 hours after the last oral dose, although there is recent data to support potentially acting sooner. Again, to the issue of frailty, nutrition and bone quality is also tied into this. Malnutrition is a very common issue in a hip fracture population, again, related to frailty. Malnutrition is a known risk factor for wound complication and poor wound healing. And so all patients who come into the hospital for this should have either preoperatively or postoperatively a malnutrition evaluation. And we do start oral nutrition supplementation, which is a high protein supplement for all of these patients. In addition, all patients with these fragility fractures or hip fractures are assumed to have osteoporosis. Vitamin D and calcium is initiated for all of these patients. In addition, these patients should have prompt evaluation and initiation of anti-resorptive medications or anabolic agents to help with their bone health. And so again, it's not merely an orthopedic problem, it's something that should be addressed from a team-based perspective in regards to generalized improvement for these healths of these patients. This is a study that was from Yale New Haven. This was a very interesting study, and I think one that can really inspire a lot of surgeons, anesthesiologists, hospital medicine doctors, and geriatricians in terms of working cooperatively to improve the outcomes of these patients. So this was an intervention at Yale Hospital where they instituted a protocol for hip fracture patients, which involved medical co-management for all patients with a geriatrician if possible, standardization of hip fracture order sets. Notably, they had a dedicated OR for hip fractures, which allowed for expeditious treatment of these hip fractures rather than delaying. As we mentioned, we know that expeditious treatment is beneficial, generally speaking. And standardization of other postoperative management, including blood conservation, the use of tranexamic acid pre-operatively, as well as judicious use of transfusions. And what they found was that they could significantly improve their outcomes after these injuries. Notably, they found a 30-day mortality reduction from 8%, which is pretty close to the national average, down to 2.8%, which is a pretty remarkable result. In addition, they found that length of stay, time to the OR, transfusion, and adverse drug events are all decreased overall. So in general, I'd like to conclude that these injuries, again, represent a major health and economic burden for our patients. It is a challenging problem with a compromised and frail patient population. These patients do have a high risk of morbidity and mortality. This is not the same as elective hip surgery, so this is something that comes up in the office or in the hospital. Patients are treated with surgeries that seem similar to surgeries they've known of or heard about for people with elective hip problems, but this is a very different issue, a very different surgery, and a very different outcome overall. We know that expeditious evaluation and treatment improves outcomes in these patients, and a system and team-based approach can significantly improve the outcomes from these patients from a functional perspective, and most importantly, a mortality and morbidity perspective as well. Thank you very much.